So You Want to Change the World, a podcast sponsored by the UNLV School of Public Health. This podcast is designed to highlight some of the outstanding work of our faculty, staff, and students, and how public health changes our world, our community, and improves our quality of life. Well, hello, I'm Dean Gerstenberger, Dean of the UNLV School of Public Health, and thank you for joining us today to hear a few more stories about how our school is out there changing the world. My guest today is Dr. Erika Marquez. I've worked with her for a very long time on a lot of different projects, so I'm excited to hear a little bit more about her ongoing research. Her work focuses on health disparities and really a lot of the connections between the built environment, the home environment, and health. And so we're excited to hear about that today. She also does a little bit of work related to our Nevada Minority Health and Equity Coalition, as well as launching some of our global health initiatives. So welcome today, and thanks for being here, Erika.
Thank you for having me.
Yeah. So let's talk a little bit about just public health, right? I know you didn't start in the field of public health. You had kind of a different background and some different degrees. How did that transition over into your interest in public health?
Oh, that's a great question. So I feel like my path has just taken a life of its own. I first started my career in studying psychology, and I thought that's what I wanted to do. And then at first, I was working at a crisis center, and I was working with youth at the time. And I realized after doing that I don't know if I wanted to work with people in that acute crisis, right?
Mm-hmm.
And then I had an opportunity to work with a neuropsychologist at San Francisco State, where I was doing my undergrad work. And she kind of changed this whole idea of what research looked like. And I got to go to Texas and do field experiments, neuropsychological testing to be specific, on a population that had been exposed to a gasoline spill, but did not receive equipment during their cleanup phase. Right. Mm-hmm. And so I really thought that maybe clinical psychology, maybe something in research. And it really changed into maybe medicine is what I want to do. So I did my entire pre-med courses. I thought, I'm going to go to UNLV and get my MPH or apply for my MPH. And that's going to be my jumping point into med school. And I came here and I didn't even realize how public health kind of just changed my vision of health and community and populations, right? And being a first generation student, it was so important to me to give back to the communities I grew up in, right? Being a first generation student, it was really important to me. But when I came to UNLV, I realized I could do so much more thinking about entire communities versus one patient at a time. And that changed everything for me. I still did the MCAT, didn't do great. And I was like, you know what? It's okay because I love this. This is amazing. And I had no idea at that time the potential of things I could work on, but I knew I was in the right place.
Well, it's cool. I think it shows that sometimes the path we end up on isn't the path that we thought we were going to go down, and how making sure you're open to those experiences, working in a laboratory, trying a research project, and then kind of getting on the end of prevention and population and community health. And sometimes it just takes a minute to find your passion, right? And you gotta go down a few wrong roads, you gotta open a few wrong doors, but eventually you kind of find your path. And I know I spoke to students to that effect too, because I was I don't know what I want to do. I said, well, most of us don't, right? Until we kind of try a few things and go, oh, I like that, and I feel like I can really make a difference, or I can be good at that here. And I know that's led you to a world of interesting research here at UNLV. I know you have a passion for health disparities and helping underrepresented groups or folks that don't have a voice. I know that's where your heart lies for sure. And I think one of the projects that you've done along that path is really looking at childhood lead poisoning prevention. So maybe you could talk about some of the different projects you've had and worked on related to childhood lead poisoning prevention and kind of how that that path led you there.
Sure. Uh, so I think one thing I've learned over the years is I had to be flexible, right? And be open to the things that came my way. I would have never told you to almost 20 years ago that I would be working in lead poisoning prevention for the next 20 years of my life. And as you know, my career started as a GA in lead. Like
Right.
it was, the school had it for, I think it was their first full year when I joined the team. And it really just started in getting a basic understanding of what the climate was like in Nevada, right? And it was a new thing for me, even though I already had an idea of how environmental health impacted people with some other, with other research I had done with an undergrad. But it really just was like a starting and a stepping stone to understand how we build an entire program, since Nevada it was the first time we'd had a childhood lead poisoning prevention program. And then we'd had some, really great opportunities to envision what this program would look like, begin to think about the implementation, and then think about all the partners we need to bring to the table to do that work, right? I think that was really eye-opening for me as a student when I started, and then as a project manager for the CLIP program. And I think over the years, we've had some ups and downs, right? We lost funding in like 14, 15, something like
somewhere
that.
around there.
The CDC defunded the program, and then Flint, Michigan happened, and then it really opened people's eyes again as to why we need programs like this, right? Why we need to monitor surveillance of children and being able to have the capacity to respond. So it was, when the opening came up again for us to reapply for the lead poisoning prevention program effort, it was our opportunity to make sure that we took this work statewide. Because when we think about health disparities, one piece of this is about being able to test children, right? And identify them. But the other point of this is also having the capacity that all our health authorities be able to respond to cases. And when we started to take this statewide in the kind of the next iteration of it, we realized that that was just a huge gap. It was a huge gap we couldn't fill in the first iteration, and we were really eager to try to get this done in the second. And so, I'm really excited that we have every single health authority on board, and we've built their capacity to respond to cases. And I think that's just been really, really exciting work to work on, is to take what we've done. We started initially with one health district. Now every health district plays a role in responding to cases.
Yeah, I want to take you a little walk down memory lane here, right? And so I remember in the beginning when the project started, there was almost nobody getting screened in the state of Nevada. So when we talk about screening, we're talking about getting our kids tested, right? So let's start there. Why is it so important to screen kids for lead? Why is this an important thing for us to do?
Absolutely. I mean, we know enough about what the impacts are on children, right? We know it can cause delays, learning delays, behavioral problems. And I think one of our biggest challenges with lead still today is that a child could be exposed but have no symptoms. Right? And that's why testing is so incredibly important. We will not know unless children are tested.
So, I know we can't say this too many times, but right? So all kids, just some kids, high-risk kids. What are we looking at, right? So often we hear we're in Nevada. It's relatively new. There probably isn't a lot of lead here. We'll get to that in a minute. But, is it everybody, and at what age should they be tested?
Yeah. So the recommendations for kids on Medicaid, we absolutely, the recommendation is that they should be tested at 12 and 24 months, or at least once before they turn age 5, right? That is the recommendation. And I think, but we also know that there's high-risk populations that may not have access to Medicaid either, that we need to consider those things. And so what we have done as a program is developed lead risk questionnaires that our providers can use to try to gauge, outside of that standard recommendation of them being on Medicaid, what could be a risk factor that would require them to be tested. So we've just updated that questionnaire already, just in the last month, and we're resending those out to all of our providers in the state, and basically looking at other things, right? So have you traveled outside of the United States? Are you a recent refugee? That could warrant you to be tested. Or what we know in Nevada and across the world is that it's not just paint exposure, right? It's not just deteriorated paint, but it's the things that we bring into our home, right? It could be the occupation or hobby your parents work on or someone in your home works on and brings that to the home that could warrant your child to be tested.
Let's talk about that a little bit, because I
Okay.
think that's important. Obviously, we know paint, right? And paint, a certain year earlier, and gasoline had that in that. So maybe you talk about those, and then talk about some of these other sources that you've seen that could cue off parents to say, listen, I'm in an occupation where I might bring home some lead and I might need to test kids. So what does that look like for those kind of three, four different sources, right?
Yeah.
It's a big question.
Yeah. So I think our most common sources that we always think about is lead in paint, right? And lead in soil, water, and dust. Those are like the basics that we all know are really important to think about when we're thinking about risk exposure. But I have to say that in the United States, lead poisoning prevention, public policies around lead poisoning have actually been absolutely phenomenal at decreasing lead exposure in children, right? We have now laws in place that reduce lead in paint or eliminate lead in paint as of 1978. And also we've removed lead from gasoline, right? These have had like very apparent effects in blood lead levels across the United States. What we're seeing a lot more now, even though Nevada, we still have older homes, right? And there's still a risk in our state. But we're also seeing a growing, and it's been like, I think there's tons of research, right, on these non-traditional items of things that we bring into our home. So it could be cosmetics. It could be your clay pots that you brought into the home. It could be so many things. It could be toys that we've imported from other countries that just don't get past the CPSC guidelines, right? That not everything is being tested when it's being brought into the United States. So all of those things really play a role of risk that haven't been like necessarily a problem we thought of years and years ago, right? When we were thinking about removing lead from all like these other traditional sources.
Yeah, and paint is such an obvious one, right?
Yeah.
As it deteriorates and cracks and peels and falls on the floor. I think one thing that people don't know is how much lead do I have to get exposed to be poisoned, right? Do I have to eat like a whole fishing sinker, right? Do I have to ingest a large chunk of it? Is this like a visible amount? And, how much does it take to actually poison a child or get enough in mom who might transmit that to the child and you could have symptoms there? So how much is that?
It's very little. It's like a few grains of salt that it takes for a child to be to have a blood lead level above the CDC reference value, right? Because we know that there really is no safe level of lead in the blood in children, and so we know that it takes just very little bit of exposure to impact a child's long-term health.
So I know some of the projects you've done have gone into homes of either lead-poisoned children, unfortunately, or homes that we think were older, built pre-78. And you identify sources of lead and then try and remove those. So there's got to be a few success stories in there where you found sources. Maybe you could tell us about a few of those. What did you find? What do you do to remove it?
Yeah.
And how does that work under some of the grants that you've had?
Yeah, absolutely. So I'll say one of the challenges before we had the grants that actually remediated exposure is like we would go into homes and identify sources of exposure. But what was really hard is that most of the communities we went into don't have the resources to remediate those hazards, right? So we had to come up with strategies on like how to best educate them to mitigate exposure, right? So, using wet cleaning methods, because we know it was about food on the table, roof over their head, or remediate the hazard, right? And they would do all of them if they could. Right.
But they can't.
Right. Because it's thousands of dollars to do that. And so I think when we started this work, it was a rude awakening, right? Because it was hard to know that we didn't have the resources to do that. We could help you identify them. So we just, did our best to try to teach them how to reduce that risk, right? But in you know, as our work evolved over time and there was HUD funding available to apply for, we were able to collaborate with the city of Henderson to be able to implement a program where we were able to now remediate the hazards we identified, right? And so, and I think in about 150 homes that we assessed during that 4-year period, I think it was, we found over 100 homes that had lead-based paint in them.
Right.
And I
So
think
it's here.
it is here.
Right.
It is absolutely.
People always say it's not here. It's a new city, but
I
that
know.
is not true.
It is not true. And it's like trying to convince people of that is the hardest thing, but we found it, right? And I think of all the grants I've managed, the HUD Henderson grant was probably one of the hardest grants to ever manage.
Right.
But it was also one of the most rewarding, right? Because not only were we going into people's home and saying, okay, we've identified this lead hazard, but we also had now the collaboration with the city of Henderson to come in and being able to use that HUD funding to remediate those hazards, right? And that was absolutely rewarding. And not just those things, but because we know we don't live in isolation of all the other things that exist in our home, right? So if they had non-working AC units, right? Or they had trip and fall hazards in the home, or there was trip and fall hazards in the bathroom, we were able to access additional funding to be able to fix those things, right? And we live in a climate where AC really shouldn't be is not optional, right? It really isn't.
It's so hot.
It is extremely hot. And, you know, we're usually in those homes testing people with, you know, they're not running their AC. So like, because they know that their windows are so old, it's not going to cool down the home, and it's a huge cost, right? And those were other things we were able to fix. We were able to like fix some of, you know, the windows and weatherizing them. So I think that
Which goes back to that resource allocation, though, right? If that lowers your power bills or it reduces allergens or things that can get in the house, it contributes to the overall health of that family. It is such a cool program.
Yeah.
So one of the things too you mentioned is you had to go out and identify these homes. There's a couple of different ways that I know that happened, right? One of the most backwards things that I think we've ever done in public health is we go out and screen kids, we figure out their lead poison, then we go to the house and remove the lead, which seems marginally unethical, right? And the other way that we do is we can go out and look at the house and remove the lead from that house, right? So that the child doesn't get poisoned in the first place. So I know there's probably a combination of those happening, right? When we would get lead poisoned kids, you would go to those, and then it's more of a I'm trying to find it kind of thing, as opposed to I'm not sure if it's there, but I want to prevent it from happening. And so I know those are very different kind of when you step in the house. And maybe you could talk a little bit about what it looks like when there is a lead poisoned child and what you look for when you go into the home.
Yeah, absolutely. I mean, I think we always go in with with diligence to trying to identify any sources that we could, right? So we're going to tackle those traditional things, right? We're going to test lead-based paint in the walls, in the rooms, you know, kitchen, everywhere that the child may have access to, right? But we're going to pay particular attention to the areas that they spend the most time, right? So that's where we're going to do dust sampling to make sure that the paint in the home that's deteriorating and dusting off, where they are crawling around or touching, or, you know, and kids are kids, they're going to put their hands in their mouth all the time. You know, you almost can't avoid that. But we want to make sure that they're not doing that with leaded dust in their hands, right? So that, I think, is one of the essential things we do, right? Looking for those traditional hazards, like looking outside in bare soil areas where they play, you know, things like that. But then I think we've done a really good job at thinking about those sources that are brought into your home, right? So let's test some of the toys that you have. Like, what are the ones that they use the most? Let's test some of the dishes that they use for the child to eat on. And we just had a case probably about a month ago that we did a lead risk assessment, and all the family's dishware has lead in them, right? And in poor condition. So like the recommendation is like, don't keep those, like get rid of those
dishes,
and
right?
replace them, right? But again, that family has the option to do that, but that's not always the option for everyone. Right?
Yeah, and those are tough. I know that would wear on you. You would find a child that was poisoned. If we didn't have a grant, you could tell them, here's some things you can do to try and minimize exposure. But if it's lead-based paint and it's deteriorating, that's tough. Or if it's a product they can't replace or can't afford to do. I think that's really one of the cool things about public health in general, is that we get these multidisciplinary approaches and solutions to solve problems and meet people where they at. And that to me is one of the coolest things, is if we can meet them where they are at and in a way that's meaningful to them, then we can really make some change and prevent some of those things. I have to ask the one question about kids, right? And so when we expose adults to lead, most of this is, I think, through consuming or eating or hand-to-mouth behavior. But kids don't seem to respond the same way that adults do. They seem to be a lot more sensitive. Is that true, or are they just little teeny tiny humans and they respond the same way?
No, we know that they're not just teeny tiny humans. No, we know that there's critical ages of development, right? And in those critical years of development, they absorb lead faster. It competes with calcium in their body. And so those are the periods of time where we're really trying to make sure that they don't get exposed, or we limit that risk of exposure. Lead is not going to be safe at any point, right? But we know those critical years of development are critical.
And that's what those screening dates are designed around, right? To go in and, because if we catch it early, it can be reversible. But if you don't catch it, that can be a continued cumulative effect that may or may not get better later in life.
Absolutely.
So it is one of those things that I do believe is 100% preventable. It's not easy, but I think it could be 100% preventable. So it's a fascinating story of how the built environment has this direct impact on human health. And I know that's been kind of another stream of your research, and now you're kind of looking at those types of things globally. How is the built environment or the natural environment impacting health, not only here in Nevada, in homes with small kids or lead-based paint, but globally? And so I know you've worked a little bit to kind of launch some of these global health initiatives. Maybe you could tell us about a couple of those global health efforts you're working on.
Yeah, absolutely. It's been, I think, really exciting phase in my career to begin to transition what we understand about lead poisoning prevention efforts in the United States to supporting local community efforts in low and middle income countries. And it has, I think over the last 2.5 years now, we've been working really closely with the Philippines and with Ghana to think about, and again, because I work from a community engaged, community-based participatory research approach, it's important for me to go in and support efforts that are important to the communities we work in, just like when we do work here, right? So it's been really great to build relationships with these countries, to think about what are the needs that they have, because a lot of them don't have the policies that we have in the United States, right? And lead exposure is a completely different animal there, right? In Ghana, illegal lead mining is proliferating in the country, right? And really having an impact on exposure sources for our vulnerable populations, not just our children, but we're also looking at the impacts it's having on pregnant women and how that then has an impact on children after birth, right? And so those are some of the initiatives we're working on right now, developing communication strategies. We're working with each of the countries to help develop communication strategies that are specific to their context and the issues that we know are happening in each of the countries. And then looking at what are our research strategies that we can apply for to help support some of those local efforts. And one that we just recently wrote with Ghana was looking at exposure during pregnancy and looking at, ways that we can mitigate and prevent exposure during pregnancies, because we know that there is a connection between lead exposure and lead and preeclampsia in women, and looking at those biophysiological pathways. And so what do we do now that we have an understanding of that this is happening to prevent and mitigate those outcomes?
So I'm smiling because when I listen to you, there's a word you keep using, and the word is we, right?
Yeah.
And I think that's very deliberate, and I think it's very important when you talk about working in the community. It's we as the city of Henderson, it's contractors, it's the lead poisoning prevention programs, it's the health district. We is something different if you're talking about Ghana. Why is that word so important to get done the work that you do? Why is the we at the center of this?
Yeah. I think COVID drove something really home for me. And helping with the response at the state, was that no one agency could do this alone, right? I think that's why we is important, right? Because I know that we all have an expertise to contribute to solving local, global problems, right? The Ghana team has a contacts that I don't have, right? They have the skill sets, they have like such different skill sets that I have. So like we all bring something to the table, and we acknowledge that in our process of developing things, because our end game is to improve health outcomes, right? Reduce exposure, improve health outcomes. And that's our common goal. And so if we learn to work together, then I think we can do more together than we can do alone. And that's important for me.
For sure. And I know you also are a big proponent of making sure that that community partner, those impacted people, are equals in that.
Absolutely.
And so maybe you could talk a little bit about how that works and how that's been infused through the Nevada Minority Health and Equity Coalition and some of your projects.
Yeah. So, CBPR, like I know even during my own public health training.
And CBPR is a community-based participatory research,
community-based participatory research. And it felt like just a beast. I don't know if I would ever figure out. To start CBPR, I think the really biggest thing is being open to developing partnerships, right? Making sure that you're not just there to direct what happens, but to listen. And I can't tell you how many times I've learned more about listening than I think I was able to teach other people, right?
Right.
And I think that's so important because everyone brings an expertise to the table. And I think one of the things that that we have to stay committed to, right? And I think it's important for me is not just building a partnership, but sustaining that. Given the current political climate, we had several grants in line to write over the last semester with both Ghana and the Philippines. And that didn't happen, right? And so we had to rethink what our partnership was going to look like right now. And so we said, hey, we're still invested in this. We may not be able to find all the funding we need to get all the ideas we had off the table, but we can still support each other, right? We can still look at, how developing health communication. So I have interns that come in and help us develop health communications with their input on what that needs to look like and all those things, right? So it's about re-strategizing what we thought we were going to do, because we are committed to sustaining that partnership and those developments. And I think those are important aspects of bringing people to the table, listening to the needs in that community, and aligning my research with their own needs. Because I always had to thought, like, this is what I want to research and this is how it's going to happen. And I realized it doesn't necessarily have to work that way, right? I can listen to what they need. We can figure out what the research gaps, and we all still win.
Yeah, and I think there's a level of mistrust in general when somebody comes in and says, you know what you need, rather than asking you what you need, right?
Yeah.
There's an old saying, you have 2 ears and 1 mouth, so you're supposed to listen twice as much as you talk.
Yeah.
And I think that is kind of the mantra in community-based participatory research is like, what is it that the community wants and what do they need? And when you don't listen to them, it is not going to succeed. It's just not.
Yeah.
So it's kind of fascinating. I know you've done a great job of incorporating students into your research and bringing them in and at all different levels. And so I'm guessing as a person who has kind of kicked the tires on a few different careers and paths, why would you tell someone who's out there maybe looking for a master's or a degree to choose public health? Not that the other degrees aren't good, but obviously you found your path and your passion in it, and how might they explore that like you did?
Yeah, gosh. You know, I when I meet with my students, I always tell them that it's okay that it's not a straight path, right? Like sometimes that works out for people.
Mm-hmm.
Obviously, that wasn't mine, right? Like I
Mm-hmm.
had
Me
to kind
neither.
of, yeah, I kind of had to dabble in things and figure out where I wanted to be, right? And so I think for students, I think my biggest advice is just being open to the opportunities. And I think I pushed myself to do things I had never done before, right?
Mhm.
But I also learned to ask for a lot of help.
Yeah.
Right along the way, like I had to learn how to write grants because I spent 10-12 years on grant funding,
Mm-hmm.
and I didn't come with that skill set. I had to learn it, right?
Yep.
Like I went to a faculty member at the time. One of my mentors is like, I don't know how to do a logic model, like
Mm-hmm.
I need help. So I think I always advise my students to be open to the different opportunities. You don't have to pick a specific topic right now. You have to build that skill set. And why public health? I just developed a passion for it, right? Like there
Mm-hmm.
was, my purpose was here. And I
Mm-hmm.
think once you find your purpose, all the other things that you haven't figured out yet is okay. But you're like, this is where I need to be. This is my home.
Mm-hmm.
And I, like I said, I wouldn't have told you lead was going to be one of my areas of expertise for 20 years. But it has led to so many other things, right? I haven't just worked on lead. I've worked on vaccine community-based
Mm-hmm.
research projects. So many things that I've had the opportunities to work on.
Right. Well, because some of those things you tried, those skills are transferable.
They are.
Right. And
Yeah.
it doesn't matter sometimes what the topic is.
Yeah.
It is learning the procedures and the process and the skill
Absolutely.
sets. And then aligning that, I think you used the right word, is passion. And I think
Yeah.
public health is a field of passion, right?
Yeah.
You got into it because you want to make a difference, jokingly, right? We want
Mhm.
to change the world. That's why we
Yeah.
named the podcast that. Because we know that people come in, they look at it and they say, I see something I don't like, but I think I can change it,
Mhm.
or I think I can make it better, or I can
Yeah.
improve the conditions for those individuals. And that is 100% what you have been able to do here in the community through a lot of those projects you have had. So,
Mhm.
hopefully you can sleep well at night going, listen, I'm fighting the good fight.
Mhm.
And sometimes it's a circuitous path on how you get there.
Mhm.
But nonetheless, I think you've had a tremendous impact. And one thing I like to point out is every one of those houses that you go into and you remove lead-based paint, there are generations of people that will not be poisoned.
Mhm.
So it is such a long-term, cool thing to think about, right? And so when
Yeah.
we do that housing-based work, I prevented not only the child that was there, but all of their siblings and all of the grandkids and the next family that's going to own that house and the family after that and the family after that. Unfortunately, the houses seem to outlive us, right? And there'll be multiple generations
Yeah.
through them. So it is such a good way to prevent things from happening that we don't want to.
Yeah.
So, well, I want to thank you for being here today. I think it's been delightful to hear about all of the ways you have impacted our community and our region and our state, and now moving out to the world,
Mhm.
right, through some of your global health initiatives. So keep up the great work. Nevada needs you. We need someone passionate to keep these programs running, and we hope you have a great rest of your day.
Thank you for having me.
Yep.